I wanted to open up with a question that I think is actually kind of a hard question, and frankly, it's one that was crossing my mind. We're a 6-hospital system, a $2.2 billion company, and I'm almost thinking, so what? And in looking at what the UCs are doing, it's not hard to imagine, as we all aspire to some degree, and I realize maybe Kaiser's in the room, but you have to admire Kaiser for what it does. They own the value chain, that is a health plan, the acute, the ambulatory, and they have a lot of flexibility and a lot of muscle, a lot of power, and a lot of experience. And to the extent that they do it right, and I know some of you may even be Kaiser patients, and if you've seen the MyChart and you've seen their other customer experience, it's truly remarkable. Well, you can see the UC beginning to think along those lines. And so while they pursue a single instance of Epic and go through all that digestion and all the rest of it, you can imagine them fanning out across their geography, because by themselves, they don't cover the geography that's going to be necessary probably to do pop health, so you can just see a few steps ahead. So I was going to ask Jeff, who like me is sitting in a community hospital system, how do you feel about that? Do you see yourself as a future collaborator? Do you run back to the CEO and say, we need to do something, we need to be part of a bigger system? What's it mean to the CIO and to your organization?
So that's a great question. So I think I have to answer that first at a personal level and then maybe at an institutional level. So on the personal level, I'm going to say that, I do like to ride a Vespa, and I think most of you know Vespa is a European, very Euro, urban style motor scooter. But there's nothing to make you feel inferior than when you're at a stoplight and the guy on the Harley pulls up next to you. So that's my personal response to being in the company of, the UC system, and of course, hearing some of the great things that being done at Scripps. So in terms of an institutional response, one thing that I didn't understand before I came to Valley Presbyterian and understand now is community hospitals are actually not going to go away. At least I don't think anytime in the near future, and that's just not an opinion from me. I think there's some substantial evidence from our board, from our CEO, and so on. And it's not opinion. It has a lot to do with the market. And so because we're not going away, we absolutely need to be partners. And we are partners in a lot of ways already. And I'm not necessarily referring specifically to the UC system, but right there in northern Los Angeles in the San Fernando Valley, there are times you can feel like you actually are in an underdeveloped country and you're needing resources that come from, that you don't have, that are coming from someplace else. So we have several telemedicine programs as an example. And the services coming through those telemedicine vehicles are coming from partners that would represent organizations like those next to me here. So I think we are very open to being a partner, and I think that we are a vehicle for reaching a population that actually you don't in any other way reach. So that's just my first response, but I'm sure there's some other thoughts.
I was going to say I completely agree. I was last week I was down in Monterey Peninsula talking to a hospital down there, a community hospital down there. I happened to sit on a board of something called Scenic, which is it's a cooperative made up of all the educational segments of the state, bringing bandwidth, and we just brought greater bandwidth to the Monterey Peninsula, specifically to 3 hospitals in the region, and we were down there to kind of celebrate this because that connectivity is going to allow us to do more collaboration than we did with the small pipes they had previously. And my message was very much the same, which is it's totally necessary, needed for the community. The community needs to be connected to some of the capabilities that the UC has, whether for us it's in San Francisco or in Davis in the north. And I couldn't agree with you more. I mean, we need to drive partnership, right? Because we are sharing patients, all over the place, taking advantage of, the location that you have or the expertise that we have. We're passing patients back and forth. That's why when we talk about, the big data initiative, we're building this kind of, I call it data as an asset. And we're building really data repositories, not just for our own use, but to be able to share with the broader healthcare community throughout the state. We're touching 14 million, Kaiser's touching 9 million. I don't know how many Scripps touches or Sharp touches or Sutter touches, but you start to talk about, we're touching 37, 38, 39 million lives here in California. We need to all be connected, be able to pass those patients and their histories to each other.
So sort of looking at the other side of that question, I think you alluded to it, but if you think about something like CHOMP, if it still goes by CHOMP, at Monterey Peninsula Community Hospital, and collaborating with them, is it all about maybe hosting them on Epic, or are you going to have to look at Meditech hospitals, Allscripts hospitals, and how are you going to bridge that gap? We all hear about interoperability.
Right.
We all have largely installed certified EHRs, and they're not quite so interoperable. We know we can do really good stuff with Care Everywhere, but there's a world well beyond Epic. How are you going to deal with that as you collaborate with others in the state?
Man, that's a great question. We can't buy everything, right? So if we buy and put Epic in, that's just not going to work. We're going to run out of money very quickly. If we partner and use Epic as a Community Connect partner, so we come in and put Epic in, but we don't acquire you, it's still very expensive and time consuming. And for some groups, it works really well, but for others, they already have a very well functioning electronic health record. They're happy. Why disrupt for years to put in a new system? So in that case, you do have to figure out how do you make this, connection to their electronic health record. And I agree with you. I think right now the exchange of data outside of the same electronic health records is poor. The CCD documents that everybody's happy about exchanging back and forth actually don't contain much information. I think that's relevant. It doesn't even contain the notes. It's really just data that you hope is entered into the medical record, but for those of you who have seen a problem list in the electronic health record, you know that that data being sent back and forth isn't complete. So we have to figure out how to do this, and I think we're going to need the vendor's help. I don't understand why Care Everywhere and Cerner's HIE are not connected, because if Epic and Cerner just did that, then all of those hospitals would be connected, for example. And so I just don't, I have some theories why that isn't the case, but we really need the vendor's help on this to do this well. Otherwise, we can't just make point-to-point connections for disparate EHRs. Because even if we all joined a health information exchange, which we're planning to join up with HealthyWay, for example, it still doesn't transmit the information you really need to take care of that patient in real time, is my belief.
So that you alluded to, or you mentioned health information exchange, and as we imagine exchanging records across a geography, let's just say the state, identity management always emerges, and we didn't get it from HIPAA. We're not going to get it from the government for all the obvious reasons, and so we spend money to largely guess who we're talking about, and we do a pretty good job of that, down to maybe 0.5%. Is there a role for CalIndex as at least identity management? Is it something that transcends the state, or are we all going to roll our own on identity management? Tom, that question, maybe you can. Is there anybody else that would like to answer this question?
I'll just say that it's a very interesting question, and I'll stop there.
Inquiring minds want to know.
Right. Well, I won't answer the question, but I'll answer it in a different way. We need to figure it out, and I don't think I have the best answer, and I don't know if CalIndex is the best solution. It may be, it may not be, but we have to figure out how to do this, and I think it's going to have to happen with the vendors of the electronic health records being involved in some sort, rather than trying to put another product and another product and another product and doing it that way, but rather use what we have to exchange the information. I don't know if that answers your question, but would someone else like to take that?
I don't know. How complete an answer was that? Can we have a vote? Are we going to use it or not? That's good. Excellent.
All right, there's some good people agreed with me, so that's good.
So I want to keep this somewhat interactive. I have a number of questions. You had a shot at the panel previously, so I'll just continue. But feel free to raise your hand if this, causes you to think about another question. We can take them from the audience as well. But you mentioned big data. I know, Tom, this is a big thing for you, and you clearly, whether you have one instance or not, as you begin to take the data into some sort of warehouse and you deal with the identity management that goes along with that, does that take data governance to a new level for you? Because we've noticed in our organization, as you begin to aggregate a whole bunch of data, its power goes up exponentially. It's why we all are a little nervous about TRW and the like, because, or Amazon, or digital dust, whatever you want to call it, they can begin to figure you out. And we can begin to figure out patients. And for the most part, that's a good thing, properly done. But how are you going to control that power when you begin to aggregate all that data? Are you going to have all kinds of security layers? You're going to have a small group of people. How's that data governance going to work?
Yeah, we're asking some of those tough questions of ourselves. We don't have that all figured out. It also, we have for us, there's also this line between when you start looking at a lot of data, is it a research project, and then it has to go through a research board, an IRB, or is it a quality improvement initiative where I'm really studying a large cohort of patients to better inform a decision, and so then it's QI, and it doesn't need to go through an IRB. And you'll get 5 different answers if you ask 5 different people in the UC today. So we're still trying to figure it out. I mean, we're looking at the policy side of it, the governance side of it. We have some pretty good governance models around certain things that we're saying, that's working really well in a certain aspect. Can we extrapolate that and use it for broader things? Yeah, I'll share a story. It was an interesting conversation earlier this week. We were talking about images, where's some of the deep learning applications for images? And, a lot of people talk about radiology. We're talking about pathology, and someone brought up dermatology. And someone just cut off the conversation like, that's a non-starter. And I was kind of surprised. They shut it off so quick, and I was naively asked why, and they say, well, dermatology images, a lot of people take images of the face, which makes you immediately recognizable, and I guess there were a couple of incidents and a couple of lawsuits filed, and so people don't go nowhere near those images, right? So you have those type of things where there's also history and sensitivities that get into, even if you put something in place that you feel works, you overlay a little bit of privacy in it, and you can blow things up. It's a complicated equation to figure out, and we're still trying to figure it out.
Scott, I'll make one comment on that. Just from, again, claiming the small community hospital perspective. For us, we have some ways to go to be, I think, good data stewards of what we have, and that does take governance, and I think that that's a given. But I just want to comment that for us, it's really a matter of survival. We can only afford to make 2 or 3 kinds of decisions on any given front. And making the right one is really important in that case, and it takes data to do that. So it may not be extremely sophisticated, but I think it's important to recognize there are sectors of the healthcare economy that absolutely require data just to be in the game and to be able to manage it well and to talk about it with the same definitions and so on and so forth. So that's just a little bit of a different perspective.
Any Business Week subscribers in here? The cover of the magazine a couple of weekends ago was an IV pump. There was a gentleman that was working actually as a subcontractor in the Mayo organization, was being very, very proactive about the security or lack thereof in a lot of these devices. It was sort of an expose. It was a rather long article for Business Week, and it was frightening to some degree. And in my organization, I'm not yet responsible for biomed, but we've been thinking about biomed devices for some time. Thousands of these things that are increasingly wireless, and they plug in with very little protection. So I was wondering, I'm sure all of you have seen or certainly know about it, is biomed inside your control? I mean, you got a lot going on now. If not, what are you doing about that new security? I mean, it's been there before, but now the world knows about it. And there'll be new hackers attempting to break in, and some of you may know, but these IV pumps, they administer medications. If you go inside an ICU, it's not uncommon to see 4 or 5 pumps running meds into a single patient. I mean, you can barely see the patient for all the tubes and the pumps and so on. And a lot of the pumps, most all of them, have inside them, formulary information that will say how much Coumadin should be given in an hour and everything else. And it's remotely managed, and those formularies can be updated remotely, and they're linked up with EHR and everything else. It's really very much high tech. They also are downloaded and maintained remotely, and it's not very hard. In some cases, there are no passwords to go in and change the flow rates, or for that matter, the rates per hour. So we got a new level of security out there that's actually very scary, that has yet to be exploited, but might be. So I was wondering where the panel was on that, because nothing will get in the way of big data, single instance, or anything else than if we have a runaway IV pump and we have a patient incident.
Scott, I think that's a great point. Anybody who hasn't read the Business Week article should, because it's eye-opening. So at UCLA, biomed is not under IT, although there are days I wish it was, because when they go purchase something, I get a phone call saying this machine is not hooking up to the network. We didn't know that you were buying the machine, and it's actually not compatible with our network, and so then we have to go back and try to fix it. But we actually have a really good collaboration, so we've gotten past a lot of those hurdles. But we've started to set up a task force between IT and biomed to determine how we're going to tackle this. There's a couple of problems. One is the FDA has strict control over the biomed devices. So we can't just go in and layer on different software technologies to protect them or change the integrated software. Then some of the biomed devices need to communicate outside of your network. So for example, CT scans, you'll have the vendor remote in to troubleshoot. And that occurs with most of your radiation oncology equipment, like linear accelerators, your radiology equipment. So unlike pumps where you can not have them communicate necessarily outside to the internet, you've got equipment that's actually accessible via the internet. And so that's even a higher level of concern. So I think we have to figure out a way to tackle this in terms of figuring out how to isolate in a very secure space this equipment, be able to understand where we're going with the vendors. So we're going to have to, again, work really closely with them to figure out what are their security flaws in the equipment and make sure it's up to date. And then for those pieces of equipment that do need to communicate out, really understand how we're going to manage those from a security standpoint, whether they need to be behind certain firewalls. Can we put them behind certain firewalls? I mean, what are we allowed to do? And I actually had a conversation with one of the leads up at the FDA regarding some radiation oncology equipment, because we wanted to put information security technologies on the servers that ran those equipment. And so there was a discussion on, well, are we allowed to do that? Does that alter what the FDA approves for that equipment? And I got to tell you, I had to speak to like 17 people before I got the answer, and the answer was, we think it's okay. So we've got, obviously we can't wait for the FDA to figure this out, but it's concerning to me that we don't really have an answer or a plan from the FDA, from the vendors, and we're going to have to figure that out on the ground, I think. So this is a good reason for all of us to collaborate, not only in Southern California, but in all the UCs, but everybody here, because we're going to have to figure out how to prevent this. Because this, stealing a medical record sucks, believe me. But turning a pump up and doubling the infusion rate, that'll kill somebody. So it's now at the next level, doubling someone's radiation dose. That's extraordinarily scary. So we have to figure out how to take care of this.
So I agree, and I think this is an area of collaboration among many of us, I believe, because we all share the same issues, and I think if biomed is not part of IT, sort of the growing trend is that it is going in that direction, or that collaboration is necessary. In our hospital, biomed is now under IT and under me. And the approach that I have to take, it's very pragmatic at the moment, but the approach I have to take is much like you would in evaluating a cloud infrastructure or somebody who's going to provide you infrastructure as a service, are they SOC, certified? Are all these different things? So in our case, our biomed is the management of it is outsourced to one of the several biomed companies that are out there. And so my first step in addressing this is to hold them as accountable to those standards as I would to a cloud provider or any other data services provider on the IT side. Doesn't guarantee we won't have the problem, but I think that's a really important starting point because we don't have the resources to actually monitor that to maybe the level that you can.
In the early days of the EHR, it was miraculous that the terminal would turn on and it would connect to the computer, and that's usually when the celebration began, and so on and so forth. But as that began to work, you could see through to the problem you never had a chance to see, which was all about the workflow and everything else, so a whole new set of challenges. And now, as many of us have gotten at some level of optimization, which is really that period following an activation of EHR, literally a lifelong journey in getting more and more value out of the system, you begin to see past that in our organization, and we have 500 other little teeny tiny applications that we have just missed before. And with all these cost pressures, we have this idea of application rationalization, or AppRat, because it represents a cost that we got to figure out how to get out of the organization. And for some number of them, they actually duplicate the function of the EHR, or they duplicate the data, or both. And I was wondering, given you're pursuing the big fish right now, the lower hanging fruit, so to speak, and it's very, very difficult. But where is something like AppRat, so to speak, on your agenda? Or do you have that problem? Do you find, I would think inside the UC system in particular, all kinds of things tucked away in closets and apps you probably didn't even know you had? Is that on your radar?
Well, this is an easy one for us. Again, in a smaller environment, we almost know every app that's out there. When you do as much VDI as we had, you can control what goes out there. I have tried to live on the principle, though, of for every new vendor or solution that you bring in, you have to give up two. And I think if we can stick to that, we stay at least within reason.
It's a huge problem. It's a huge problem. There we go. For us, there are a lot of apps, I think, that are circulating around, a lot of legacy apps that don't like Internet Explorer 11, for example, and really like XP. So it's really how can we consolidate. So when we put in our Epic system, we eliminate, I think, 173 apps by consolidating onto one platform. So that there's huge benefit to that. Now, obviously, Epic can't be best of breed in 173 different applications. So you're going to have some, decrease in your workflow or reduced optimization because it isn't, a perfect system, but it allows us to at least consolidate. So we're constantly trying to figure out what's on our network, how to eliminate applications that are old, legacy, or don't conform to the appropriate security standards, and then move them onto a newer platform. And that's something we're working, I think we discuss a lot with the UCs, other UC CIOs. We look at all our application portfolios across the systems to see where can we consolidate, where have people done better. If we need to move to another application to replace a couple others, what else are people using so we can basically leverage that scale.
Maybe just, I saw this in two med-device companies when I was on that side of the world. Sold healthcare IT products, so then was part of the problem. And now watching 5 health systems do it, and I watch 10 campuses do it. And if we think healthcare is bad, triple it, and that's what a university campus looks like. What I get across all those experiences is, it's kind of it gets a little bit better as the enterprise platform proliferates and adds more and more complements in terms of its available modules, like you can get rid of 173. We have a student information system going at the Berkeley campus. They're going to get rid of 248. And they have 362 left, right? So, but for everyone that you're able to take out, it seems that because of how slow the enterprise package moves, you're coming up with some new innovative tool that's coming up for the deficiency on the edge, on the new edge of innovation where you need to be. So, it never really goes down to a level where I think it's more manageable. If anything, I think CIOs are doing a great job if they can keep it at a level state, because I've yet to see an organization that for any period of time has actually shown drastic improvement to it. And again, that's looking across 3 industries.
Questions out here? So CIOs encounter routinely people running breathlessly into your office saying they need to get one thing or another. And maybe that's true. There are a lot of creative people out there, and they're actually at the problem. They're at the bedside, and they really do understand the business, and we're really looking for that kind of thing. But it gets to the application issue. But speaking of that and innovation in general, we're all so busy, and there's so much going on with pop health frankly, it seems like every day we continue to refine that definition of pop health as what it really means. And I think it's somewhat in the eyes of the beholder and somewhat specific to the organization and their aspirations in that space. But, how do you deal with that? How do you deal with, are you being sucked into innovation? Are you leading innovation? Are you able to innovate at all? And how are you maintaining your agility, if you will, and your responsiveness with this huge workload? Or is that just something you can't do right now? Are you segregating staff? I'm just wondering how you have a certain amount of flexibility, sort of people at the ready when there's so much work to be done.
It's a huge challenge, and I think mobile health, so we had a talk on mobile health earlier that was really fantastic. I think mobile health is actually a huge benefit for us. So mobile applications are fairly easy to develop. You can put infrastructure in to make them fairly secure. You can limit what they interact with in terms of your electronic health record. And it's, can be very innovative for faculty and for clinicians at the bedside because they can accomplish what they want to. So what we're trying to do at UCLA is carve out a space to allow innovation in the mobile health sphere that is secure, easy, uses platforms that, like Salesforce, for example, that are fairly easy to program, and then we can control the security layer and the API layer such that we can allow our faculty to innovate and create these apps. Now, the problem with that is once they create these apps, if they are successful, then the faculty member could disappear. And so you have these apps that patients are using, and then the faculty member goes to USC, for example, and so we don't talk to them anymore. And that's a joke, USC. They beat us really bad in football this week, so I'm still a little upset about that. So we're going to have to pick up those applications that are successful, I think, from an enterprise level, because our patients are going to depend on it. But I like that space as a place for them to innovate. But you're right. I mean, I have a lot of people coming in saying we want this new, piece of software, or this tool or that tool that is going to take us months to implement. And rather than being able to state how this tool is actually going to improve their care, it's more about, I just want this tool. And so what I try to do is I try to not push back, but say, okay, well, what is the problem you're trying to solve? Let's forget the tool, because there's probably 50 tools that could solve what the problem is. And it's surprising how many people cannot articulate that and then disappear. And so that strategy has worked well for me. And then those who can really articulate the problem, we try to help them. And then we try to solve the problem, and we end up going down a route that they never even dreamed of, and come up with a solution that's even better.
So I want to touch for a moment on this idea of the productivity paradox. I think there was a little bit of that in the early morning keynote, and I would highly commend you to go back and look in the literature back into the early 90s, what that's all about. But fundamentally, it takes some period of time before productivity is seen to improve after the introduction of a technology. And it's been repeated over and over again. And the real observation, for which I think the guy may have won a Nobel Prize, but it takes 6 or 7 years at least, which on average is probably the period we're in the middle of, or maybe nearing the end, on the EMRs. And we have note bloat, we have work after clinic, we call it. We've got the inbox hell, I think you said, but whatever it is, it's a challenge. And they said, until you reimagine the work, which you can't reimagine the work until you're in the middle of it. And we're in the middle of the EHRs. And so we're looking for a silver bullet, as you mentioned. And maybe there isn't something like Athena. You would hear, Jonathan Bush say that Epic's no good and we need something simpler. I think the answer is more complex than that. But I'm wondering where you all are, because you've been at it for some time, in reimagining the work. And it's not that the EHR is going to go away. And that's not to say there isn't something simpler that'll sit atop of it. And maybe it's some population health strategy. But do you have formal programs to reimagine the work? Are you monitoring or measuring clicks? Because we literally hear, it takes me an extra 5 clicks. It takes me 25 clicks with this new upgrade. What's wrong with you guys? Because clicks are time. So how are you going about, and to what degree are you reimagining the work? Are you reimagining?
All right, I'll talk again. So I think there's 2 problems. One is, and you've done an incredible job with optimization of your Epic system, but I think it only goes so far. So we can tweak this and we can turn that and we can put this button here and we can, but in the end, there's only so much we can do. If you think about it, let's say you have a physician who sees 15 patients in the morning and 15 patients in the evening, so 30 patients a day, which is pretty common, if not low. And in the electronic health record, there's a fixed cost of every visit in the ambulatory setting. Say it's 5 minutes. It takes you 5 minutes to write the worst note possible, click your billing, click your visit diagnosis, update the problem list, check the medicines, check health maintenance. Okay, that's probably only a couple things. I'm not including reviewing the chart and pulling in records from someone else. But say just 5 minutes to do that. How much time is that just doing the minimum to complete your day in the EHR? It's not that hard. 5 times 30, 150 minutes, right? So over 2 hours of time that's gone just using the EHR and the way it's designed. So, I mean, we're always trying to optimize. We're putting together the physician happiness team, which is actually going to be a group of high-level Epic trained architects that go to clinics and figure out where are the biggest pain points. And that will help. And physicians like to be heard and like to think we're helping them. But I'm never going to get them below that 5-minute fixed cost until we change the way that notes are written. How do we do that? Well, we're not going to get anywhere until the 1996 billing rules have changed, because it requires 9 different, for a physical exam, it requires 9 different systems, 2 different points in every system. It requires a 14-point review of systems. I've never met a doctor who does a 14-point review of systems, but every single doctor documents they do a 14-point review of systems. Why? Because that is, if you don't write that in your note, you get $0 for that visit. The whole thing is ludicrous. So until that changes, I don't think we're going to make a dent in the notes. So we're in EHR 1.0 right now. We need to get to EHR 2.0. It's got to look different, but it's also got to be driven by the guidelines, the billing, the regulatory. All of those pieces need to align with a new way of practicing medicine. And that's the only way to do, and you'll drive that fixed cost down. In the inpatient setting, and I'd be curious what you think about this, I get very little complaints because you don't have that fixed time pressure. And having to find charts that would often disappear when the patient is gone, being able to write orders wherever you are instead of calling in verbal orders and trying to find the nurse has saved a lot of time and has increased safety. So I rarely get complaints on the inpatient side. Where I get the most complaints is on the ambulatory side. And again, I think it has to be completely rethought on how we do this. I know it.
Just a couple of thoughts. So, we to the earlier question, Scott, we really can't afford to have an innovation garage in our IT department. But from the standpoint of reimagining work, because we have some ability to collaborate with the forefront of our care delivery, we have had a few Kaizen, lean type events where the metrics and, the issues have all been about saving minutes. We actually did something recently in our ER that increased throughput tremendously, and it was a collaborative, lean event facilitated by people that do that all the time. And so the IT component was the recognition that you make sure there is somebody there from IT in those events, and that they can translate what they're listening to into something actionable that supports what the others are determining is really going to save that time. And so really innovative ideas came out of some of these workshops. And now this is very interesting. We even had one of the facilitators say, I didn't know your Meditech system was so flexible. Okay. And the reality was, no, we had a very innovative analyst present in the event that could envision what that might look like in a Meditech system. So I think that's at least the type of partnership we need to be able to provide to get somewhere there. In terms of the other innovation, I'm hoping you guys figure it out first and I can just follow.
So I have 12 more really good questions, but I noticed that it's 4:23 or 4, and we're supposed to have closing remarks at 4:15. So, no, I'm not going to overrun our schedule. I mean, I started several minutes late, but seriously, I don't have 12 more questions. I was kidding. But I have one more question. So let me ask one more question. Fair warning, one more question. So it was generally about cloud computing, which you mentioned, and I was wondering how you felt about cloud computing, and I was wondering when this data center, or 16 or 18 data centers you have, would all disappear into Amazon services for that ultimate cost savings at scale. Do you see that happening? About when? I guess that would be to you, Tom.
Yeah, I see it happening.
Okay.
When, I think, is a harder question. I think it was Clark Kegley said, other industries do this. Why do we feel it's so difficult with healthcare? Why do we feel like we have to be so different all the time? And I think there are things we should be different on, and I think there are things we shouldn't. And this is one of the things I think we shouldn't. Other people deal with sensitive data, so I'm hoping it's in a 2 to 4 year horizon that we could be comfortable as an industry, generally as an industry, putting certain types of information, not all information, but certain types of information into a highly scalable, robustly available environment, and just get out of the business. One of my colleagues up north is a guy by the name of Mike Kale. He happens now, he's the EVP over at Yahoo, was at Netflix before that, and he says things like, I want to get out of the IT business. What he's really talking about is he wants to get out of the core infrastructure business and let people who have a core business of doing that. I think we as healthcare providers, I think we would all love to kind of get rid of that more commodity-based stuff and to really spend our good cycles and our good talent on the higher end of healthcare where we really feel we can make a difference. So to me, it's a yes in 2 to 4 years, I hope.
Wow.
So I agree with Tom. I can't wait to get out of the data center business. We actually looked at moving our data center to the cloud, and it was cost prohibitive when we made the decision to go with a co-location model with the northern and southern data centers. So I think in 2 to 4 years it won't be. And it will be silly for us to maintain our own data centers, I think. It's going to, Amazon, Google, Microsoft, they're going to figure, they figured it out. They're going to do it better than we can. And so I'm really hopeful that we start to do this in 2 to 4 years. In fact, I'd like to do it with research, and we're actually looking at this within a year, start moving that kind of data into the cloud, not, healthcare research, and then, continuing to learn from that. But I think in 2 to 4 years, it'll be cost effective at that point.
Wow. Yeah. Okay. Yeah, to me, it almost looks like a decade. Partly because our apps, Epic being one of them, for example, doesn't exactly lend itself to running in an Amazon cloud. It's not built the way we need it. At the same time, we might put our analytics, our warehousing, and other things up there with all due regard to protections and the rest of it. So it's going to be a migration, but I don't know that we'll ever truly extinguish the data center, but it certainly can be a lot smaller and cheaper to operate. But we got apps in the way too.
Right. I mean, and as Epic is moving to HTML5, and they're moving very slowly, but that would be
Right.
a very, very important move for us to be able to move that into the cloud. I think that's, right now the environment to set that up is very complex. So I agree with you, but we may be able to move pieces of it into the cloud in the near term.